Hi, I'm Dr. Rena Azar, and today I'm going to talk a little bit about naughty bladders. So I'd like to talk with people a little bit about the fact that postoperatively bladders may not wake up very well. Part of that is because bladders are organs that get tired after surgery. Surgery is a stressor for your bladder, and repositioning it is a stressor for the bladder's function. So when we go to sleep, all of our body parts go to sleep. Sometimes the bowels are a little delayed waking up. Sometimes the bladder is a little delayed waking up. Also, bladders can be positionally challenged. In other words, and you'll know if you're one of these people because we've talked about your anatomy, but bladders in some people are hanging down. They're hanging down, and when you stand up, the balloon-shaped bladder, the lower part is having to push the urine up and out to empty. But when I put the bladder in a new position, it is no longer the under part of the bladder that's doing the work. So for years, you've used the under part of that balloon-shaped bladder muscle to push the urine up and out. And when I reposition it so that it's upwards in the pelvic cavity, it is now the upper part, the dome of the bladder, that's having to squeeze the urine down and out, down and out. So the upper part of the bladder is thinned out and wimpy and sometimes poorly coordinated because it's not been used a lot for the last few years. So that physical repositioning of the bladder can make it so that this part needs to wake up and strengthen. So for people whose bladders are asleep because of anesthesia, just anesthesia, usually within a couple days at the most, the bladder will wake up and function well. But for people who have a low-lying bladder that has now been repositioned into a higher place in the pelvis, and once again, the upper part is now having to do most of the work as opposed to the lower part, those bladders might take a little while because they have to build up their strength. I'm going to talk a little bit about something that I've probably talked with you in the office about as well. I like to emphasize to people that not only are those two factors part of how bladders wake up and delay in bladders waking up, there is another risk factor. People often have neurologic damage that was done to the bladder at the time of childbirth. And that neurologic damage can result in frequency or urgency because of the poor communication between the brain and the bladder, but also delayed contractility. In other words, people who have nerve damage don't have good coordination of the bladder muscle. Sometimes when I reposition the bladder, we give it a little time, sometimes some physical therapy, that coordination of emptying of the bladder will get better. But if there's a significant amount of neurologic damage, then the bladder may not be able to receive the brain signals that are coordinating all those muscle fibers to empty out at once. And unless you've got something like a neuromodulator that I've placed, or you've done PTNS to help to coordinate the nerve signaling between the brain and the bladder to allow the brain to contract all those fibers at once, emptying might be slow for you. And at the time of surgery, for many women, I'm also unfortunately tightening or correcting the position of the bladder so that it's harder for the bladder to leak. So if I make things a little tighter or position things so that it's a little harder to empty and you have an already lazy bladder, we'll see it after surgery, and that can cause delayed bladder awakening, delayed bladder function. So Kristen and Deb and I will watch you closely postoperatively. We know how often to give the bladder trials, how long to leave the catheter in, and if you are an outlier, if you're having to wear a catheter, you're having to come in very frequently because of poor bladder emptying, we'll talk with you a little bit about the neuromodulation that can be used to wake the bladder up and to make it coordinate better so that long-term you can have better emptying results. So each person is individualized in their management. I do tell people, though, most everybody will have some delay or some little bit of dysfunction in bladder emptying for a while after surgery, simply because we did surgery. And I like to remind them that if you have hip surgery, you use crutches for a while. If you have shoulder surgery, you use a sling for a while. The bladder only has one way to relax it, and that's called a catheter. So sometimes we have to use that postoperatively beyond the first day or two, while the bladder is waking up and learning to function. And sometimes long-term, we have to look at neuromodulation to help the bladder to empty strongly enough to push beyond the support that we've given the other pelvic structures that make it a little harder for that bladder to empty if it's uncoordinated. So we'll definitely talk with you about that at more length at office appointments in the future if your bladder has a problem waking up. But bladder trials after surgery are not uncommon, but we'll still look at getting you restored to normal function. So please be patient with the poor little bladder.